Everybody, and welcome to Facebook Friday on Friday the 18th of September 2020. It's lovely to be back with you after a couple of weeks break, so thank you to everyone who's joining today, and special huge thanks to Simone, our CEO from Neuroendocrine Cancer, who held the fort very steadily and capably while I was with Facebook Friday, whilst I was enjoying some time in the garden. Just before I continue, I'd just like to acknowledge the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people, and I would like to pay respects to their elders past, present and emerging. One of the things I love to do on this land that I am very grateful and lucky to live on is to run by the Yarra River, which in the Woiwurrung language is called the Birrarung. So I've had a chance to do that quite a lot over the last 3 weeks, and but it's really fantastic to be back in the space with our unicorns, and I'm here to give you another update this week. So I'm rusty, so please bear with me if there's a few more ums and ahs than usual. I'll try, and I've got a few notes, so I'll try and cover all of my points. But if you see my eyes darting down madly, it'll be because I'm just making sure I remember everything. Okay, so firstly, I wanted to thank our fantastic volunteers who have so beautifully looked after both of our online support groups. So our main private discussion group, which is where I'm broadcasting into you today, but also our carers group. So our main private discussion group, our volunteer moderators are Denise and Katie, and our carers group have Sylvie and Mel. And that actually reminds me that it's probably a good idea for me to just mention the carers group. We maybe don't talk about it very much in our main private discussion group, but this is a really important and special space for people who are carers for people with NETs, and we know that that can be quite a lonely, I'm not going to use the word journey, but you know, it can feel quite isolating to be a carer, and so it's really important that our carers have a space just for that private conversation. So if you're a person who's living with neuroendocrine cancer, that's a space that's not for you. But if you're a carer of someone with neuroendocrine cancer, make sure you check that out, and I will put some links in the notes about the carers group. It's very similar to this group in that it's private, so your Facebook friends can't see that you're in the group, and they can't see the conversations in the group, so that's only visible to the other members of the group. So the other thing I just wanted to say up front is that you might notice, for those of you who know these videos, I've got my candle burning today, and that's because I've sadly come back from my holidays to learn that one of our dear unicorns has passed away over the last 3 weeks. And actually this person was not part of our Facebook group, so many of you may not have encountered this person, but actually, or you might not think that you have encountered this person, but maybe you might have. So and I'm talking about our wonderful, beautiful Fran from Queensland. Fran had been living with NETs for a very long time, for many years, and in fact in my first week working with neuroendocrine cancer, I attended a conference down in Hobart. Fran and her husband Daryl spend 6 months of the year down in Hobart over the warmer months when they're not spending time in Queensland, and they actually met me at that conference to meet the new NET nurse, and that was like 5 years ago. But I will never forget the warm welcome that Fran and Daryl gave me, and Fran was such a special person. And one of the things that Fran did over a long time, which many of you may have been touched by, is that she would make these felt love hearts. So I've just realised it's got a shiny plastic cover on it, so I'm going to take it out of its bag so you can see. It's a tiny felt love heart, and it's just slightly soft, so it had a little bit of wadding in the middle of it, and it was for people with neuroendocrine cancers. It said, if it were not for hopes, the heart would break. This pocket love heart has been made to share and celebrate kindness, and keep it close and give it a squeeze when you need a reminder of love, hope, courage and comfort. And Fran made gazillions of these beautiful little love hearts for people to hold when they were going for their treatment or for their scans. And we actually sent these around to the various face-to-face support groups around Australia. So it may be that you've got one of these little love hearts that Fran made. And we're so grateful to her for doing that beautiful work of love and creativity for all of our unicorn community. She was a really crafty person, and she would make lots of beautiful creations and sell them at craft markets as a fundraiser for Unicorn Foundation and Neuroendocrine Cancer Australia. So Fran, I've got a special warm place in my heart for you, and I'm going to miss Fran dearly. So I just wanted to to acknowledge that. And from time to time, you might see the candle burning. Sometimes it's someone that we will know in our Facebook group. Sometimes it might not be. Sometimes it might just be burning, and I might not actually go into the personal, the whys or the wherefores, because it might not be, the right time. But I just wanted to say that about Fran today. So I always start with a bit of an update about COVID-19, and it was really gratifying in Melbourne, which is where I am, to see the numbers starting to feel a little bit more manageable. Sadly, we've really seen the delayed fallout from this virus in Melbourne, and we've had a horrible number of deaths in Victoria because of this. But the incidence numbers were really very, very grateful to see them coming down, and we know that's because everybody has been so amazing at staying locked down and staying inside, and I know lots of you in Melbourne have had to do that, and I know also there's a lot of people from interstate who this has had a really direct impact on their ability to come for treatments, particularly at Peter Mac. So thank you for those who have come forward and let us know if you're struggling. If that's still you, do get in touch with us, because we've been able to do some advocacy work for people in this sort of situation to either make that a bit easier or to link you up with alternative treatment teams. So just to say that out loud. The other thing just to say is that it's been a really long time. Like I haven't really been out of my house socially since the start of March, and I know lots of people are in a very similar situation. But even if you're in a state where there are less numbers, there's still this this cloud, and it's the focus of every news bulletin. It's the focus of so many social media posts, and I think that there's a level of fatigue. Certainly for me, there's a level of emotional fatigue. I've had to unfollow some people in my personal Facebook feed that were getting, that were just needing to express their frustrations, but I was finding that emotionally difficult, and realising that it was absorbing a lot of my energy and a lot of my time and my thoughts, and it may be that for you that you do need to kind of curate your diet of what you're reading online to, I guess, maintain as much emotional wellness as you're able to. So I just wanted to again just acknowledge that it's been a long time that we've been living with this virus. One of the things that I've spoken about heaps is that we're part of a cross-charity collaboration with lots of the other cancer charities, and we meet every fortnight. I'm actually going to be meeting with them next week. One of the things that we will be talking about is the return potentially for face-to-face support group meetings, and how we go about setting up things like COVID safe plans for those states where there are minimal numbers, and working out, for groups that might start meeting, what would need to take place for that to be as safe as we could make it. So that's just one of the things that it's on my radar as I come back to work this week. So today, as promised, I wanted to talk a bit about nets and connective tissue, because it's a thing that comes up. It's an important aspect of health for many people with nets, and so I just wanted to drill down into that a little bit and to give you some more information about how all of that works and what we need to do about it. the first thing I wanted to talk about is, well, what is connective tissue? Because, you know, you might have heard the term bandied around. Often when we think of connective tissue, we think of, you know, fish oil and cartilages and knees getting creakier as we get older and all that sort of thing. So you might be thinking, well, what has NETs got to do with connective tissue? Well, actually, connective tissue is a far broader family of body cells than even I realised until I was doing some homework for this talk today. It's certainly you know, the sorts of things that you might think of, so tendons and cartilage and that sort of thing, are all very much part of the connective tissue kind of system. But also, who knew? Fat. So adipose tissue is actually technically connective tissue, so I didn't know that. And also blood is technically considered to be a connective tissue. So I was sitting looking at my medical textbooks this morning going, oh, there was, you know, I've been a nurse for a long time, and so there's not that many surprises, but that was a surprise for me. So what is it about NETs and connective tissue? And the first thing to say is that, like lots of things, everybody's different, so not every NET will have an impact on your connective tissue, and not all connective tissues seem to be affected by NETs. So, you know, I sound like a broken record every time I remind people that everyone's an individual and every NET is different. So there's the main hormone, so it's hormone producing tumours that we worry about with connective tissue, and it's the primary hormone that we think is responsible is serotonin, which is secreted by lots of small bowel tumours particularly, but other tumours can produce serotonin as well. And so there are some other hormones that kind of have some question marks over the top of them as well, and it's things like histamines and other ones that aren't in my mind right now, but serotonin seems to be the main culprit. And as I said, not every part of your body's connective tissue system is going to be affected. So, you know, we don't really have any evidence that it affects things like knee cartilage or those sorts of, or our fat. Some of you may wish it would make fat go away. Other people might wish that they had a bit more on them. But unfortunately, we don't seem to think there's a relationship there. But there's two parts of the body that, if you've got a serotonin producing tumour, are more susceptible to being affected by that serotonin. The way you know whether you've got a serotonin producing tumour is if you get carcinoid syndrome, is the main kind of measure. So if you get the flushing and the diarrhea and the shortness of breath, that's called carcinoid syndrome. If you don't get carcinoid syndrome, you've got much less risk of being affected. So there's two main areas, as I said. So there's the heart, and there's what's called the mesentery, which I'll tell you a bit more about in a minute. But I just wanted to briefly talk about both of these areas. Both of them can have, you know, whole Facebook Fridays attached to each of those things. So, you know, this is going to be just a bit of a dip into these two areas, and we might come back to them if there's lots of interest. So the first thing is carcinoid heart disease, you might have heard of, and it's the reason why people with neuroendocrine tumours need regular echocardiograms. So up to 40% is what I read in the literature of people with carcinoid syndromes will develop carcinoid heart disease. And what happens is that the blood that is leading from the small intestine, that's or from the liver, that's full of hormone that's being produced by tumours, sort of washes through the heart, and it in the heart are what we know as valves. And if you can imagine a valve, a heart valve is supposed to be this very flexible, soft piece of connective tissue that flips open and flips shut and flips open and flips shut with a really fluid motion, and they're gossamer thin. When they're normal, they're very, very delicate tissue, and they're made of connective tissue. But what can happen is that when they are soaking in this serotonin saturated blood that's leading from areas where there is tumour, that can affect the connective tissue of those heart valves, and they can what we call fibrose. So you can get plaques, so build up on the valves. You can also get sort of like a shrinking or a thickening, not only of the valves, but the valves have little like almost little guy ropes or strings that connect them to the wall of the heart to stop them sort of flipping inside out the wrong way. It can make those little fibres actually sort of shrivel a bit more too, which can mean that the valve doesn't shut completely properly. And what happens then is that when the heart squeezes, the blood, rather than going in the right direction, sort of squirts through the wrong way through the valve and comes back into the venous system where the body's trying to get rid of it. And what that means is the heart has to work harder to pump the same volume of blood around the body. And this can lead to things like shortness of breath or fatigue. It can lead to sort of fatigue and the heart muscle becoming overworked. And it, you know, obviously, like in time, that can lead to heart failure. So that's something that people, especially if you get carcinoid syndrome, we want to be checking your heart. And the way we do that is with an echocardiogram. And in the echocardiogram, they are particularly looking at the right-hand side of the heart. Often with age-related valve issues in the heart, they're looking at the left-hand side of the heart, because the left-hand side of the heart is like the workhorse. That's the part of the heart that's the biggest and has the biggest workload, because that's the part of the heart that's pumping blood into the arteries, and it's got to be at a fairly decent pressure. The right hand side of the heart doesn't usually get too many problems unless you've got carcinoid heart disease. So when they're doing their echocardiogram, they're actually looking at a slightly different part of the heart than they might be used to looking at. So the radiologist who is doing that procedure, they need to have on their slip when they get the information about the test that they're doing. That needs to include, you know, the neuroendocrine, the fact that it's a neuroendocrine tumour, and they need to be looking at the right hand side of the heart. We might be using words like tricuspid or pulmonary valves are the two valves that are in that area. So that's like a very, very, very quick chef's tour of carcinoid heart disease. And we do have a video on our YouTube channel by a cardiologist called Dr. Daniel Chekic, which I'll put in the notes as well. And he's been able to go into it, obviously, with his expertise and a bit more time, into a whole heap more detail. So I will make sure I post the link to that video in the notes. But the other area that you might have heard me refer to is the mesentery, and that's not a, you know, we've all heard of our hearts, but most of us, unless we're a health professional, won't have heard of our mesentery. So the mesentery is a sort of like a collect. I've been thinking all morning, what would I compare this to? It's a bit like a mushroom of soft connective tissue that lies within the gut, in the tummy, and it connects the bowel to the abdominal wall and keeps it all nicely arranged with itself. And so when the mesentery is sitting there, it's, if you can imagine a picture of someone's intestines, you know how they look like sort of sausages. They're all looped around and they're sort of softly folding, but there's no knots on. And also when we stand up, if we didn't have the mesentery, all of our intestines would kind of drop to the bottom of our tummies. So the mesentery all keeps it in a nice arrangement, whether we're lying down or standing up. And mesentery is connective tissue. So what happens is that if you've got a tumour in your small bowel, particularly, that's producing a lot of serotonin, that can cause the same kind of fibrosis that happens in the heart, that can happen in the mesentery. And what we find is that that gets fibrosed as well. Now, you know, I'm one for a metaphor, and it probably doesn't look anything like this, but the way that I think about it is, if you've got a piece of Glad wrap that's covering a bowl of soup in the microwave, and you put, it's cheap Glad wrap, it's not Glad wrap, it's your home brand one, put it in the microwave, it gets some steam on it, and especially, I don't know, it doesn't seem to happen so often. I think they've improved the stuff, but back when I was a kid, if you put Glad wrap in the microwave, it would kind of shrivel and get really thick, and you couldn't spread it back over your food. It would just go yucky. So that's how I imagine mesenteric fibrosis to be. And what it means is the bowel, instead of lying in those beautiful relaxed loops where the food can pass through, your mesentery can kind of draw in and essentially kind of create like a knots and tight curves, tight corners, and sometimes even obstruction in where the bowel is supposed to be nice and you know, letting all of that food that's digesting through. So that can cause pain, and it also can cause bowel obstructions. So that's often a reason. Sometimes people ask me, and I know we did a session on surgery a few weeks ago. I'll put a link to that one in the notes as well. But that's sometimes a reason why they might decide to remove a small bowel neuroendocrine tumour, even when you might have other tumours growing somewhere else in your body. So taking out the small bowel tumour won't stop it from spreading because it's already spread, but it might prevent so much hormone being in the region, and it might help prevent that mesenteric fibrosis. So they're the two areas, and that's sort of what they're about. That's how they are. I'm just going to have a little quick look at the questions and see if there's anyone who has asked me questions about that. And you're all sitting very silently, so I don't know, maybe you've all gone to sleep, or maybe you've just confused, or maybe it all makes sense perhaps. So really importantly, what do we do? What do we do about carcinoid heart disease and mesenteric fibrosis? The other thing before I go on to what we do about it, I did read some interesting things, and I'm not an expert in endocrine system, and I'm not a surgeon, I am a cancer nurse. But it did strike me as interesting that there were a couple of mentions in the literature around fibrosis in the pancreas and the pancreatic duct. I'm interested in that. I need to find out more. So it may be some homework for me, but I just know that for some people that pancreatic duct can be problematic, and so my Kate brain is thinking, what's going on there? So I'm putting it on my list to ask the next doctor I talk to, and they'll be rolling their eyes and going, here's another doozy from Kate, let's see if we can answer it. I'll let you know if I work out what the answer is to that. So what do we do? So the first thing, always we say, prevention is better than cure. It's all very well to say, well, what do we do about this heart with fibrosed valves? What do we do about this mesentery that's fibrosed and drawing the small bowel in and causing obstructions? But obviously, if we can get to it before it gets to that point, then that's fantastic, because then we save ourselves a whole lot of drama, much easier to prevent it. So the first thing is early diagnosis, because we know that for a lot of people with NETs, and I know Simone has been talking about this quite a bit over the last few weeks, the delays in diagnosis are unacceptable. And if someone has had carcinoid syndrome for years, and often you do, right? So if you've had carcinoid syndrome for years, all of those high levels of hormone have been in your blood for all of those years, and it means that there's a slightly higher risk of damage happening to those parts of your body. So we want to get people earlier, and that's why we're doing things like the GP education program, and also just really encouraging people that if you've got symptoms, go and see your doctor. If it doesn't get better, go back to see your doctor. Don't just give up. Go and see a different doctor until you find an answer. So the other thing that we want to do, so for someone, we know they've got a neuroendocrine tumour that's producing serotonin, we want to get that serotonin level down as much as we can. So the key way we do that is with somatostatin analogues. So that's the lanreotide or the sandostatin LAR injection that people have every month. And actually the rates of carcinoid heart disease have been reducing over time, and we think probably that's because people have been on these treatments. And so that's a way of reducing the amount of serotonin that's in your bloodstream. It's actually one of the reasons that people might be on these drugs in an ongoing way, even when the tumours don't seem like they're growing or doing very much, but the thought is that it might be protective against those carcinoid heart disease and mesenteric fibrosis. The other one that is a newer drug that is not a somatostatin analogue, and it's not a monthly injection, but it's another drug that has been approved for use for diarrhea with carcinoid syndrome. Beg your pardon, I've still got Kate Holiday brain. So if you're on the monthly somatostatin analogue injections and you're still getting particularly the indication is diarrhea, then they can put you on a drug called telotrestat. In Australia, the trade name is Zermello, which starts with an X, so it's telotrestat. And actually that works in a different way to somatostatin analogues. I've talked about that drug in the past. I might see if I can find that video too. It's just going to be like my notes are going to be a massive amount of links to other videos. I'm sorry, this is such a rabbit warren, isn't it? But telotrestat actually reduces the serotonin levels that the tumours are able to access to produce to squirt out. So talotrostat is another drug. Now, there's not clinical trials to ask, that drug, whether it actually protects against carcinoid heart disease and mesenteric fibrosis, but a lot of doctors wonder about that, wonder whether talotrostat might be protective. So again, if you've got carcinoid syndrome, you're having your monthly injections, but you're not really getting a lot of relief, you're still going, you've still got a lot of diarrhea, flushing, shortness of breath, it's really important for you to not just think, well, of course I've got a neuroendocrine tumour, of course I'm going bright red, and the diarrhea is part of my new normal. It's really important not to get sucked into that trap, and talk to your doctor about the fact that you're getting ongoing symptoms. And there's a couple of things they can do. Sometimes they will increase the dose of the somatostatin analog. Sometimes they'll increase the frequency of that injection, so you get it every 3 weeks rather than every 4. Sometimes if you've got ongoing diarrhea that's in the face of those injections, then maybe talotrostat might be something for you. So the other thing is that PRRT, so the peptide radionuclide therapy, the peptide receptor radionuclide therapy, that also reduces tumours' production of these hormones that make you so sick. So, there's lots of things that we do in terms of treatments of NETs that will reduce the amount of hormone and protect those organs. So the other thing is surgery, and I talked about that before. So in the small bowel, sometimes taking out that tumour in that spot will just reduce the amount of hormone that's in that region, the local circulating kind of serotonin that's affecting that connective tissue. But the other thing is, if you've got a heart that's got valves that are damaged because of carcinoid heart disease, they can sometimes do a valve replacement surgery. Now, that is enormous surgery, and we've got some people in our Facebook community who have had that surgery. It's complicated. You have to be quite fit and well in order to have the surgery, because it takes a lot of it's big. Usually it involves a big cut in the chest, some days in intensive care afterwards, and usually several weeks of recovery. There is a new technique that is being trialled where they are replacing the valve. So clever, but they're actually able to use a vein in the groin and feed up an artificial valve all the way up through the circulation system to the heart, and once it gets to the heart and they get it in the right place, they do something magical on their end, and it pops the artificial valve open, and so it sort of sits replacing the valve that was diseased. So that's minimally invasive valve replacement surgery. Now, I've got one lady who's waiting for that to be done, and she's waiting for that to be done in Melbourne, so we're all locked down and hanging out to see how that goes. And once that happens, if she's well and everything, then I'd love to have her on. We've had a chat about that, and she's happy to share her experiences. But I know a few of you who have had the open heart surgery for valve replacements, and I just know that it's a big deal. It's not a little walk in the park. One of the reasons they sometimes will look at doing that valve replacement surgery is if we're looking towards wanting to do peptide receptor radionuclide therapy, because you need to have really good heart function to have that therapy. So that'll sometimes be the workup. So some of the tests that they'll do leading up to that treatment will include having a really good look at your heart. So let me just make sure, I'm looking at my notes and just making sure I've covered it all. So what we do is preventing. So early diagnosis is really key, but also the treatments that we use for neuroendocrine tumours, such as the somatostatin analogues, talotrostat, and peptide receptor radionuclide therapy can all help reduce those circulating levels of hormones down. We've talked about the surgical options, so valve replacement and taking out that tumour, if we can, out of the small bowel. So these are all some of the things that your team will be thinking about when they're thinking about the impact of your neuroendocrine tumour on your connective tissue system. So look, that's just such a brief sort of chef's tour. I can see that someone has asked about talotrostat with hot flushes. We don't actually have any evidence that it does help with hot flushes. Now, it kind of, you'd think it would. And when I asked my colleague at the pharmaceutical company who make that drug, I said, well, surely it should, because it's reducing your serotonin levels. And they said, well, we don't have the evidence from the clinical trials. But it's been a while since I've asked anybody. I know there are some people in the group who are on talotrostat. Does it make any difference to your hot flushes? Let us know. We would love to know, because sometimes, you know, the information they get about side effects and benefits in a clinical trial, you know, there's more things that we find out about after that trial's finished. So maybe there is a benefit that we don't have in data, you know, that we don't have in a journal article, but, you know, I'd be really interested to hear your experiences about that. Someone did ask also about the normal number for serotonin on your blood results, and I will put a link in the video to the blood test video because that's a whole nother rabbit's warren. I have to tell you, I would feel completely in Alice in Wonderland going down all of those rabbit holes. The short answer is every person's different with that, and we're talking about chromogranin A, we're talking about the 5-HAA, which are both indicators of hormone levels in your body. Some people, they go up and down depending on what the tumours are doing. Some people, they stay, you know, the same. We would expect to see a raised chromogranin A for someone who's having carcinoid syndrome, but there's not a hard and fast number that I can tell you. If it's over 20, 100, then it's terrible, or there's no hard and fast number. With those blood tests, it's more about the overall trend. So we're looking at them over the months and the years to see what direction they're heading on a graph, and that can tell us what your tumours are doing. So sorry, that's not necessarily a very satisfactory sounding answer, but it's the best answer I can give you about that one. And so we've actually got someone in the feed who's just had valve surgery, and I don't think I've spoken to you before that. I'm not going to mention names because this goes a bit more broadly than our Facebook group, but I would love to, I'm sure we would all love to hear your thoughts about what that was like for you. So that's all I've got to say about neuroendocrine tumours and connective tissue, but maybe there's more questions that you've got. So feel free to make a comment and we can come back to those questions in our group space. I did want to just give a plug to, if there are things that you would like me to be focusing on in the coming weeks in Facebook Friday, now's your time to sort of mention it, because I'm really starting to plan out and think about what we want to look at regarding neuroendocrine tumours, you know, in the next few months. So let me know. I've got some really great ideas, and I'm looking forward to sharing those with you. We'll have a few guest experts and a few just with me. But yeah, I'm so excited to be back from my holiday, and I've got so much energy, and I'm really raring to go with this. So I can't wait to start, I'm thrilled to be back. What can I say? Just a couple of things that I wanted to say before I finish up. The first thing is super important, is that our consumer advisory group, or you will have heard me talk about our consumer advisory group many times. They are such a central and vital group within the Neuroendocrine Cancer Australia organisation. It's a group of volunteers that are all from different parts of Australia, so we've got representatives. We aim to have representatives in each state. We meet regularly via Zoom conference. Sometimes we're lucky enough to have face-to-face meetings as well. And there's someone who has had a neuroendocrine tumour or has cared for someone with a neuroendocrine tumour. And we really aim as much as possible to get as broad a kind of representation from our community as possible. So we've got an amazingly rich sort of mix of skills. We've got people in that group who have research skills. We've got a medical scientist in that group. We've got people who've had experience running small businesses, so we've got people who've done fundraising. So there's, so many different passions and strengths of the individuals in that group. You don't have to be, a Rhodes Scholar or super, highly qualified. Actually, we're often looking for people with fresh eyes who can look at a patient information brochure and say, well, that word doesn't make any sense to the average Joe blogs. Let's make it more simple. Or they might look at a picture and go, nah, that's too complicated for the average punter. So, it's doing things like reviewing information for patients. It's reviewing research projects. It's giving really important feedback about where the gaps in our work are, and this is things like the GP education program have been born out of that. The Getting Results study that lots of you participated in to look at the communication of scan test results with patients. So that's all coming out of the Consumer Advisory Group. So and sorry, this is a long way of getting to the point, which is we have vacancies. So we have a vacancy in Tasmania, and some of you will have remembered that gorgeous Carol Dorgello died a couple of months ago now, and so we do have a vacancy in Tasmania. And look, we know Tasmanian people do it really tough with neuroendocrine tumours. The main multidisciplinary team that those patients get referred to are across the ditch in the mainland, and a lot of people in Tassie live, not only do they live rurally or regionally, but it's a long way from, and not easy roads to navigate to a doctor who knows what they're talking about. So there's particular issues in Tassie that we want to really make sure are at the table. The other state where we've got a vacancy is in South Australia. So we've had a fantastic representative called Jackie Barrow, who was with our Consumer Advisory Group from the very beginning when we formed in 2016, and even before then as a key advisor to Simone Layden in looking at the direction and the priorities of our organisation. So she's retiring, and we have a representative vacancy in South Australia. So if you are a person who's been affected by neuroendocrine tumours, either as a patient or a carer, and it's not a huge time commitment. We meet usually every second month for about an hour, and then there's quite a bit of emailing and things that goes on between then. But we know everybody's health is fickle, and so there might be some times where you can contribute a lot, and there might be times where you need to take a bit more of a back seat, and that's absolutely fine. You don't need to be a person with 8 spare hours in a week. We'll never ask you for that much, but if you wanted to give it, then we'll find things to keep you busy. But particularly sharing a story, working out what's important for our organisation. So we've really got our finger on the pulse of people who are directly affected and impacted by neuroendocrine cancer. Make sure that we're spending the donor money that comes in the most wise and appropriate and fitting way that's really going to suit the needs of those who are directly affected. So I'm going to leave it there, because on reflection, when you're digging in the garden, you get a chance to think about how things have been, and I just think I ramble too much, and I've probably rambled a bit too much. So I'm going to finish it off there. Thank you everyone so much for joining in. It's been lovely to connect with you all. I hope you have a great weekend. I hope you manage to catch some outdoor air and some sunshine, if there's some sunshine to be had. I will look forward to talking with you all next week on Friday at 1 o'clock if you're in the eastern states. And so thanks for tuning in, and we'll look forward to seeing you again soon.